So hopefully you all see that in the top left-hand corner of your screen. Good afternoon, good morning to all of you. I'm Gail Iwamasa, the chair of the Veterans Affairs section of Division 18, Psychologist in Public Service. Welcome to today's webinar, Helping Veterans Quit Tobacco Use Treatment in VA. We have an amazing presenter today. I'll introduce in a minute. What would be super helpful, if you all look at the bottom bar on your screen, there is a chat box where you can, converse back and forth with yourselves. And then there's a Q&A box. If you have any questions for Dr. Hamlett-Berry during the presentation, if you could include that in the Q&A box instead of the chat box, that will be helpful to me. I will try to monitor both boxes as best as I can. But the Q&A box is really to make sure that Dr. Hamlett-Berry, is able to address specific questions that you have. Okay, so let me introduce our speaker. Dr. Kim Hamlett-Berry is a National Program Director for the VA Tobacco and Health Program and is responsible for the development of policy and initiatives to support evidence-based tobacco use treatment in the VA healthcare system. And she is going to share with us today all of her expertise relating to helping veterans quit. Take it away, Dr. Hamlett-Berry. And Kim, are you there? All of a sudden your audio.
Yep, here you go. Can you hear me fine now?
Yep, sure can.
Perfect. Hi, Gail, thanks for inviting me today, and thanks to everybody who joined. I'm going to give an overview of a variety of aspects with regard to what we know about smoking and tobacco use and treatment generally, and I'm happy to provide additional or more in-depth information to anybody else who's interested in any of these topics, but just really wanted to give an overview to show that smoking is really more than about concerns about health burden with regard to lungs and the cardiovascular system, and also to talk a little bit about why as mental health professionals we need to be involved. So this is just a brief list of some of the things I'm going to talk a little bit about today in terms of what we know about the health burden of smoking and tobacco use, some of the more recent products in terms of talking about this topic just beyond the topic of cigarette smoking. I'm also going to talk a little bit about what we know about smoking and mental health, because most of the focus in years past has been more about what we know about the disease burden for physical health. I'll talk a little bit about what constitutes evidence-based treatment, and then I'm going to talk a little bit about some specific VA resources we have in the area of mobile health. So it seems like a very long time ago, but in January 2020, the U.S. Surgeon General report, most recent report on smoking cessation was issued, and the major takeaway message has remained the same for many years, that tobacco use remains the #1 cause of preventable death, disease, and disability in the U.S., really accounting for about 1 out of every 5 deaths in the U.S. and about 90% of lung cancer deaths and 80% of COPD deaths. In addition, folks know that cardiovascular disease causes more than 640,000 deaths each year in the U.S., and approximately 4 of those cardiovascular deaths is caused by smoking. And the health burden isn't basically restricted just to smoking. We also know that smokeless tobacco can cause oral, esophageal, or pancreatic cancer. So again, what we know, nicotine is a highly, highly addictive substance, and the tobacco industry has invested a lot in the past few decades in making sure that cigarettes basically are a very, very effective delivery device of nicotine. In thinking about the approach to treatment of tobacco use, whether you're a patient or provider, it's important to remember that tobacco use is a chronic relapsing condition that is difficult to treat, and it is difficult for people to quit. When we talk about veterans, when we look at the U.S. general population of veterans, there was an MMWR that came out in 2018 that said about 21.6% of all veterans in the U.S. Currently smoke cigarettes. The news is a little bit better for our veterans who receive their health care through the VA healthcare system. Most recent data from the survey of enrollees in 2020 shows that 13.3% of veterans in care in VA identify as being a current smoker. And I know that number is lower than what a lot of people expect. This is just a graphic showing something that when we talk about that 480,000 deaths each year that are attributable to cigarette smoking, this is the breakdown in terms of cardiovascular disease, lung cancer, pulmonary disease, but also secondhand smoke, that we know that among there are 9% of deaths attributable to smoking are in non-smokers who have diseases that are associated with chronic exposures over the years to secondhand smoke. Smokeless tobacco really doesn't get quite as much attention, but it is something that our patient population uses as well. Smokeless tobacco contains about 2,000 chemical compounds, including about 28 carcinogens. The levels of very harmful tobacco-specific nitrosamines can be as much as 100 times higher in smokeless tobacco, and the nicotine levels are higher in smokeless tobacco and stay in the blood longer by virtue of how this product is used. While there's not a lot of research on treatment for treating smokeless tobacco use in comparison to smoking in terms of randomized clinical trials, we do know that behavioral counseling for treating someone who uses smokeless tobacco is very similar to what you would do with somebody who smokes with only minor modifications. And of course, use of medications is much the same as well. In terms of what we know about the disease burden associated with smokeless tobacco, because it's something we don't talk about as much, basically, again, smokeless tobacco does result in higher physiologic dependence because of the higher nicotine content and the way in which smokeless tobacco is used in terms of kind of a steady state throughout the day. It may increase risk of death from myocardial infarction, coronary heart disease, and stroke. Smokeless tobacco has been found to cause oral cancer, esophageal cancer, and pancreatic cancer. Some of the health professionals who may first detect some of the problems with smokeless tobacco are actually our dental health professional colleagues. In addition to more routine things such as increased cavities, tooth decay, tooth loss, among those who use smokeless tobacco, dental professionals may be the first to see some of the precancerous lesions that present in these patients. Another tobacco product that receives a lot of attention over the past decade are what we use in terms of an umbrella term, electronic nicotine delivery systems. So these are Ecigs, vapes, vape pens, e-hookahs, tank systems. This is a very broad universe of products. The main features being that they all deliver aerosolized nicotine. They can also be modified in some cases to include other substances such as THC that's inhaled. E-cigs are considered or, quote, deemed tobacco products by the FDA because they include nicotine that is basically a tobacco-derived product. And in terms of some of the most recent numbers, in 2017, 2.9% of all U.S. adults reported they used e-cigs every day or some days, the majority of users being a much younger population in terms of what we see. In terms of what we know about health effects, we're still finding out what we know the health effects of ENDS might be. And again, this is further complicated by the fact that there's so many different kinds of products. Again, they deliver nicotine sometimes in higher doses than what's used and seen in terms of cigarette smokers. We know nicotine can affect fetal development. These products also contain additives or substances that may be carcinogens. You hear other health issues associated with in years past have been problems with some of the devices exploding, causing burns or other injuries. A large review by the National Academy of Sciences, Engineering, and Medicine in 2018 did determine that some chemicals in e-cigs can cause DNA damage as well. I think when we think about what to tell our colleagues and to tell patients who say, gee, what about e-cigs? The CDC has really summed this up in a wonderful way of saying safer doesn't necessarily mean safe. So while these products are less harmful than traditional cigarettes, long-term risks still aren't clear. And there's also increasing evidence that shows that e-cig use can include the increased risk of transitioning to smoking cigarettes in some populations as well. In terms of questions we get a lot as a program is, gee, are e-cigs helpful in helping people with quitting smoking? E-cigs really haven't been, there's limited evidence that e-cigs have the potential to benefit adult smokers if they're not pregnant, if they use them as a complete substitute for regular cigarettes and other smoke products. The problem is there's lots of dual use in terms of people who are transitioning from cigarettes. And again, these have not been found to be effective or safe as a cessation aid because the manufacturers have applied more as tobacco products as opposed to the application process through FDA that's needed for a medication or therapeutic. In terms of what we know about veterans and tobacco use, one of our best sources is the VHA survey of enrollees. If you're not familiar with the yearly VHA survey of enrollees, this is a wonderful data source. We've been collaborating with them for some years to include routine questions each year about smoking and more recently questions about other tobacco use as well. I always differentiate a little bit about what we know about tobacco use in veterans in the US general population versus what we know about veterans in our healthcare system. There was an MWR in 2018 that basically looked at aggregated data from 2010 to 2015 from the National Survey on Drug Use and Health and looked at individuals who responded who identified as veterans. At that time, 29% of veterans in that survey identified using at least one tobacco product. 21% were current smokers. 7% used two tobacco products concurrently, and that's not uncommon. About 5% were smokeless tobacco users. If we compare that with what we know from the most recent findings of the 2020 VA survey of enrollees, we see a slightly different picture. We actually saw a drop in the rate of current smoking from the 2019 to 2020 survey among veterans enrolled for care in VA, dropping from 14.6 to 13.3% of all the enrollees reporting that they smoke cigarettes either someday or every day. We also, for the last 2 years, asked about smokeless and e-cig use. About 5% of veteran enrollees report using smokeless tobacco every day or some days. Again, very similar to the general population. 3.5% of enrollees report using e-cigs or other vaping products. So again, it's a little bit lower. Some good news pieces are that we know that of those who identified as former smokers, about 164,000 who identified as recent successful quitters, meaning they no longer smoke, they identified as quitting in the last year. So that's really wonderful. Of those who tried to quit for more than a day, but who were unsuccessful, which was about 54% of all veterans who identified as being current smokers, less than 35% use cessation medication. So we still have a lot of people who are trying to quit cold turkey or without the benefit of evidence-based interventions. So we've even begun asking questions in this survey of among current smokers, how many are aware of what VA has to offer them in the way of care? 36% were unaware of NRT as a treatment option, but 70% were unaware that tobacco cessation counseling is something that VA provides. This is just a really nice graphic of how the rates of smoking among veterans in care have gone down. From in 1999, 33% of those enrolled for care are reported being a current smoker to more recently the numbers we see. And again, veterans who want to quit smoking. Over half of current smokers tried to quit in the last year. And more importantly, 75% of those who reported ever smoking are now former smokers. So our population does have really wonderful success stories as well. Again, what do we know about the use of these products and ends among our population? About 1.5% said they used e-cigs or vapes every day, 2% said they use it some days, and again, the highest rates of use were seen in those younger than 45 years, with about 8.7% of those younger than 45 saying they used e-cigs or other vaping products. I'm going to focus a little bit more about smoking and mental health. I feel like when I first got assigned as a psychologist at VACO, responsibility for smoking and tobacco use cessation, all I heard was the story about smoking and what we know about cancers, about lung disease, about heart disease. And as a psychologist, I feel it's really important for us to be clear that as the nation's largest provider of mental health care, that we really show that we're focusing on the effects of smoking with regard to its effects on mental health and on mental health populations, specifically in VA. In terms of sort of the classic study, which really first brought awareness to the issue of smoking as a health disparity issue among patients with mental health disorders, a study by Lasser and Associates that was published in 2000 really showed how patients with a mental health disorder are 2 to 3 times more likely to smoke than patients without a mental health disorder. Those with substance use disorder, those with serious mental illness being among the populations that smoke at the highest rates. And on the average, individuals with a mental health disorder die several years earlier than individuals without a mental health disorder. And many of these deaths are attributable to smoking-related disease. In terms of additional information about this, it is really true that in the US and I think internationally, the story of the reduction in the rates of smoking among the general population is really a great public health success story. And between 2004 and 2011, the rates of smoking among individuals without mental illness declined significantly nationally. However, the rate of smoking among those with mental illness really only changed slightly over that same time. Number of studies that really have pointed to, and I've indicated some of them here, in terms of how past on cigarette use is much more likely to be reported in adults with any mental illness. The rates of tobacco use, more specifically smoking, continue to be much higher among these populations. The good news is that for adults who are receiving mental health treatment in the past year, those individuals are much more likely to have reported quitting smoking. So there are ways in which this is being integrated into mental health care as well. When we look at the health effects of tobacco use on mental health populations, again, there are a really wonderful national study of veterans with schizophrenia, bipolar disorder, other psychotic disorders, and major depressive disorders found that patients with psychosis were much more likely to die of heart disease, with smoking and physical inactivity associated with heart disease-related mortality. Tobacco-related disease accounts for approximately half of the mortality in individuals with schizophrenia, bipolar disorder, and depression. A very important VA study by Bonner and Associates found that tobacco use disorder predicted future suicidal behavior in veterans independent of age, gender, psychiatric disorder, service connection, and severity of medical comorbidity. And I'll talk a little bit more about this relationship between smoking and suicide in a minute. Patients with serious mental illness smoke at much, much higher rates and suffer a much heavier disease burden with regard to smoking. They, in fact, have even been, these populations have been targeted in the past by the tobacco industry that in the past has done things like provide free cigarettes to mental health institutions. Patients with schizophrenia who also smoke are much more likely than those who don't smoke to have higher rates of hospitalization. They require higher doses of medication than schizophrenics who do not smoke because they're constituents of tobacco smoke that induce the liver enzymes to more quickly metabolize medications, antipsychotic medications. They are likely to have more severe psychiatric symptoms. Also, and this number is probably gross underestimate now, individuals with schizophrenia who smoke spend approximately 27% of their monthly income on cigarettes in a study looking at outpatients. Given the increased cost of cigarettes with increased taxation since that time, that percentage is probably even higher now. Patients with schizophrenia who smoke are also more likely to die from heart disease or cancer-related tobacco use. A study that found looking at individuals with schizophrenia and bipolar disorder, current smokers had poor cognitive functioning and poor functional outcomes than past or never smokers. So again, these are just some of the ways in which smoking is affecting mental health populations. Among substance use disorder populations, SAMHSA reported in 2011 that 75% of individuals aged 12 and above who were entering treatment for substance use disorder reported current tobacco use. Smokers have poorer long-term substance use outcomes than non-smokers who are also in substance use disorder treatment. Tobacco-related diseases accounts for 50% of deaths among individuals treated for alcohol dependence. One thing that I first ran into when doing this particular area and talking to colleagues who had been working in substance use disorder treatment for a long time was sort of a lot of the thinking that if you sort of work with these populations to get them to quit smoking, there would be the fear about that they would have relapse into alcohol or other substances that they'd been working on their substance use disorder. This is a common myth. A lot of people have written about the research that actually shows that the opposite is true, but this is something that some providers still basically express concerns about. Dr. Sonia Duffy, a VA researcher, actually did something very similar to what the Lasser studies looked like that I talked about a little bit earlier in 2000. Dr. Duffy and her colleagues looked at the smoking rates among VA patients with mental health or substance use disorders in 2012. At that time, veterans without a substance use disorder or mental health disorder, about 15.9% reported being a current smoker, and you can see how those rates are much, much higher among individuals with schizophrenia, PTSD, bipolar disorder. substance use disorder. This was basically also found among the National Survey on Drug Use and Health, which found that 48% of U.S. veterans with serious psychological distress reported being current smokers as well. The relationship between suicide and smoking is one that's getting increased attention and is an interesting one. The takeaway message is that smokers appear to be at greater risk for suicide, although the specific reasons are unclear. Smokers are more likely to contemplate and plan suicide. They are more likely to attempt and die by suicide than non-smokers. As I mentioned earlier, there was the VA study that found tobacco use disorders were associated with a 36% greater risk for suicide in a prospective cohort study. So this again points to the need to always assess for mood and suicidality in these populations, to think about monitoring people as they move towards trying to quit. In our mobile health interventions, we also make sure that they all basically tie to the Veterans Crisis Line as well. The benefits of quitting on mental health and substance use disorder outcomes is an important issue. Receiving a smoking cessation intervention, either during treatment or later in recovery, is associated with a 25% increased likelihood of long-term abstinence from alcohol and drugs. Recovering alcoholics who don't smoke saw a greater improvement in cognitive functioning versus those who smoked. Quitting smoking is associated with reduced depression, anxiety, improvements in positive mood. The effect sizes for this are equal to or larger than those of antidepressant treatment for mood and anxiety disorders. So this is an important thing you can do for your patients who have symptoms of depression, anxiety. In a longitudinal study, daily smokers with mood or anxiety disorders at initial interview had a decreased risk of diagnosis if they quit smoking before follow-up intervention 3 years later. I'm just going to briefly talk a little bit about what constitutes evidence-based treatment in terms of tobacco use cessation. Again, the 2020 Surgeon General report, really important message is that smoking cessation is beneficial at any age. Quitting smoking improves health status and enhances quality of life in any individual who's able to quit. There were some just high-level takeaway messages that many of them were consistent with other things in terms of in the past, the U.S. Public Health Service clinical practice guidelines and others. Almost 70% of adults who smoke want to quit, 50% try to quit each year. The gold standard of treatment continues to be behavioral counseling plus FDA-approved cessation medications that work together to increase likelihood of quitting. We know from the overwhelming preponderance of data that combination nicotine replacement therapy is more effective than monotherapy. We also know that tobacco cessation quitlines continue to be A-level evidence in terms of effective behavioral interventions to help patients with quitting. And the data is also emerging to show that text message programs and web-based interventions are effective in increasing smoking cessation rates as well. One message that we always try to emphasize and make sure that providers also pass on to their patients is that tobacco dependence really needs to be treated sort of within a chronic disease framework, requiring repeated interventions and multiple attempts to treat. It is incredibly important to treat not just the physiological, but also the behavioral components of dependence. On the physiologic side, the addiction, again, to nicotine and medications that help with a very difficult transition in terms of symptoms of withdrawal and cravings when someone quits, but also the behavioral piece. And this is something that sometimes patients have to be talked into a little bit more because they're like, well, why am I needing counseling for this? I just really need that NRT or that pill that you can give me. But for patients who've been smoking 10, 20, 30, 40 years, the routine of that cigarette with particular parts of the day is something that's been ingrained in their behavior for decades. And smokers will sometimes say, you know, gee, my cigarette is a source of support to me. So helping people with finding other ways to enjoy that first cup of coffee in the morning, or, you know, a drive, or doing something with their friends, or what are they going to do instead of smoking, and really breaking down and delinking those behaviors is really a critical part of treatment for success. We used to talk about in the past it would take people 5, 6, 7 times to quit before they may quit for good. And in fact, research has indicated for some of smokers who've been smoking for a long time, it may take many, many more times than that. But again, just remember that at any given time, 70% of smokers really want to quit. 1 in 10 may successfully quit in a given year, but we have a lot of people who are still trying to quit without evidence-based treatment. And that's just being a really brief slide showing how there's really a dose effect. Higher number of counseling sessions are more effective in supporting abstinence, and combining counseling with medication makes it even that much more likely the patients will be successful in quitting. The medications, as I mentioned briefly, play a very important role. The symptoms for withdrawal can be irritability, restlessness, cravings, insomnia, symptoms of depression, hunger, difficulty concentrating. If you've ever known somebody who's a smoker who's trying to quit, you've seen how hard this is for them. And so we know that medications play an important role in managing those withdrawal symptoms and coping with the urging to quit early on. In VA, the first line PBM formulary options, basically we typically advise providers to think about using combination NRT as opposed to monotherapy for patients because something like the patch provides a steady state of nicotine, and then the gum or the lozenge can help somebody with breakthrough cravings that they can just use as needed. Bupropion can also be combined with forms of nicotine replacement as well. Varenicline has had a very complicated history in VA, and I'll talk really briefly about that. But varenicline is still a second-line medication, but it is second line in the sense that it should be considered for a patient who has any previous history of failure of monotherapy or combination therapy in terms of NRT or bupropion. It doesn't have to be within the past year. It doesn't mean that the patient has to try it again and then fail before they're on it. As any of you have been in VA for very long know that there was a great drop in prescribing of varenicline from 2008 to 2016 due to some FDA advisories and box warning I'll talk a little bit about. Very large international trial with over 8,000 patients that was published in 2016 found no significant differences in neuropsychiatric adverse events with varenicline versus a nicotine patch or placebo. And the criteria for use of varenicline has been revised a number of times since then. And FDA, more importantly, removed the varenicline box warning in December 2016. Two really important publications, if you're not aware of them, to be aware of. One is there was a JAMA study that was published by a number of VA researchers. The lead author was Desai. The senior author was also Dr. Bernie Good, who was a PBM for many years and a Pittsburgh VA provider, on varenicline nicotine replacement therapy use associated with the US FDA drug safety communication, sort of looking at a timeline of what happened with those FDA safety warnings and what happened with utilization of medication over the same time. I was around then. So in 2007, varenicline, we worked to have varenicline added to the VA formulary. We saw like a peak in use in the first quarter in 2008. This medication was being effectively used. The Wednesday before Thanksgiving in 2007, the FDA issued initial safety communications regarding possible neuropsychiatric events. And VA very quickly looked at what we were doing as a system. That was elevated to a public health advisory by FDA in 2008. By that time, there had been a 68% decrease in utilization of varenicline in VA. Comparably, among Medicaid populations, there was only a 38% decrease in utilization. FDA issued a box warning in 2009, and again, the Eagles trial by Dr. Antonelli, a former VA researcher, was published in 2016. 6 months later, FDA lifted the box warning, and 12 months following Eagles and following us really working to get the word out, utilization of varenicline increased by 42%, but I think we still have a long way to go. The Eagles study, or evaluating adverse events in a global cessation study by Dr. Antonelli and Associates, was a randomized double-blind trial of over 8,000 smokers across 140 international centers comparing varenicline, bupropion, nicotine patch versus placebo. The design was also intentionally included 4,000 smokers motivated to quit with psychiatric disorders, as well as 4,000 without, 12 weeks of treatment, 12 weeks follow-up. The primary endpoint was incident of moderate or severe neuropsychiatric event, as well as efficacy endpoint was biochemically verified abstinence, weeks 9 through 12. Again, the major takeaway findings, and we keep doing everything we can to inform providers about this, is Eagles did not find an increase in neuropsychiatric events attributable to use of varenicline or bupropion relative to the patch or placebo. varenicline was more effective than NRT, bupropion, patch or placebo, with, of course, bupropion and nicotine being more effective than placebo. So it's really important to understand that the early safety warnings about a possible signal were actually not borne out in a number of large studies. There's also a VA study done by Dr. Fran Cunningham and Associates, the VA Center for Medication Safety, that found similar findings. We also very early on needed to get across the message that smoking cessation medications needs to be available for any smoker or tobacco user, whether they wanted to quit or not, because there have been previously limitations. We know that medication is a highly, highly cost-effective and effective intervention, and that veterans who say, gee, I really don't want counseling right now, but I want medication, while we'd like them to get behavioral counseling as well, it is certainly appropriate for patients to continue to get medication if they do not want to be in counseling. Behavioral interventions, there is just a wide way, as we've seen in the last year, in terms of the way behavioral counseling for tobacco cessation can be delivered in terms of in person, over the phone, telehealth, individual, group formats, and really any healthcare provider who has behavioral counseling in their scope of practice can deliver behavioral counseling for tobacco use treatment. And I see a lot of variability across the system. It's changed a lot in the last 5 to 6 years, with many more pharmacists getting involved in terms of having their own pharmacy-based clinics. Certainly nurses play an important role, psychologists, psychiatrists, social workers, addiction counselors, and there are even dentists who have this as part of their regular intervention with their patients. Also, the evidence is clear that quitline coaches can provide deliver counseling of the phone. Again, dose effect with more sessions, longer sessions, we see increased likelihood for success, covering things such as triggers, coping or avoiding triggers, and really helping patients to think about how to remove tobacco from their daily routines. Because I actually, as a psychologist, started out in public health as opposed to mental health, and it's been a wonderful transition to mental health, but basically looking at this from initially a public health approach, you know, we recognize that we provide care for a population that's characterized by a number of factors that are strongly associated with smoking, including former military service, mental health and substance use comorbidities, higher rates of homelessness, disability, lower SES. And so we really, at the onset, adopted a comprehensive public health approach to increase the reach of tobacco use treatment across the system. Through promoting evidence-based care, we've adopted policies to reduce barriers to treatment. We've targeted disparity populations that continue to smoke at much higher rates. We've also developed and implemented mobile health and telephone-based interventions to reach those veterans who maybe aren't coming in through the door of a VA medical center on a regular basis, to really think about doing whatever possible to reduce the rate of smoking among veteran populations in VA. As a national program office, sort of the two levels we work on this is we invest a lot of time and energy on developing all the things that providers need to deliver evidence-based care so that they have at their fingertips the information they need about what works best, whether it's patient-provider workbooks, handouts, information sheets about how to use all the various medications. We have them in Spanish as well for veterans whose preferred language is Spanish. We also provide throughout the year ongoing clinical trainings as well. The population level, again, we have implemented mobile health interventions to supplement what goes on in our healthcare system so that we can basically promote to veterans directly information about the SmokefreeVET text messaging program, our national VA quitline 1-855-QUIT-VET. So the VA quitline took a lot of work. We rolled that out in 2013 through an ongoing collaboration with the National Cancer Institute. Any veteran who receives their care in VHA can call Monday through Friday, 9 a.m. to 9 p.m. and hopefully are right away connected with a quitline counselor who can talk to them about what their goals are, help them formulate a plan. It's a proactive quitline, so up to 4 scheduled follow-up calls are scheduled at the veteran's convenience. Counseling is available in Spanish for veterans whose preferred language is Spanish. We also invest in training the quitline counselors because our quitline is part of the National Cancer Institute quitline to make sure that our quitline counselors receive the Operation Save training once a year so they know how to identify veterans who are at distress and who need to get a warm transfer to the Veterans Crisis Line, and they do that routinely. Quitline counselors are not healthcare providers. They don't have access to VA health records. They do not prescribe meds. They can answer basic questions about how do I use the NRT patch or gum, but for any VA callers with questions about medications, they're referred to their VA provider. And this is just a quote from a veteran here on this graphic who called back. A lot of veterans call back to say, hey, I quit, I'm doing well, and thank you guys for all you did. We look at, through our program evaluation, how do veterans find out about the quitline in terms of the questions they're asked when they call the quitline. Top 3 sources are provider, print materials, web. Average age is 56. 86% of our callers are male. 95% of our callers are cigarette smokers. This is just a brief sheet, and we have resources that you can look at. But basically, we also talk to providers about knowing what to say. How do you frame what a quitline is and what it does and what to expect so that patients are much more likely to engage? We also evaluate the different ways in which veterans come into the quitline, not unlike what happens with quitlines in states as well. For veterans who call on their own because they saw the number or someone gave them a card, about 44% of them initiate ongoing counseling and continue sessions. 89% report using medication for their quit attempt. That rate is still much, much higher than the non-VA quitlines. In terms of warm handoffs, where we have providers talking to the patient on the phone, it actually only works on a landline, unfortunately not on a cell phone, and they say, gee, it sounds like you're interested in the quitline. How about we call together and you talk to I'm going to refer you to them and hand off, and the veteran consents to that. 70% of those patients initiate and continue counseling. 97% report using meds. We also have sort of an electronic referral or e-referral. It's secure message referral, but it's not the secure message portal that most VA providers think about. It's the one that's used for community providers. That works very well in terms of we have some sites that are using that and set up a pilot where there's a clinical coordinator who basically has discussed the quitline with patients. They've consented to being contacted. And so they're just their name and phone number sent through a secure portal, and the quitline contacts them as well. And again, that's really more effective than veterans calling on them in terms of basically enhancing engagement. Our SmokefreeVET text messaging program is something we're really proud of. We actually launched that at the same time in 2013, again, through collaboration with NCI. It's a program where we send veterans sign up by texting VET to 47848 or VET ESP in order to receive the messages in Spanish. They then get 2 to 5 messages a day, beginning 2 weeks before their quit date and continuing 6 weeks afterwards. They get tips, support, all evidence-based strategies to use. Includes information in terms of some of the text messages about the quitline if they would like to use it. The Veterans Crisis Line is a resource. You can get, without signing up for it, you can type in now the word urge to 47848 on your cell phone, and you see what a veteran would get in the way of a message if they are having a craving and they're looking for a tip or strategy about how to deal with a craving. In terms of, how we talk to clinicians about this, because it was initially a novel thing to basically think about how do you frame an automated text messaging service for clinicians. It is not to replace what happens in the way of any behavioral counseling that somebody's receiving as a provider or getting through a clinic. It's more of basically a treatment extender. So thinking about it, it's an additional source of support. Eric Augustin, a psychologist who was at NCI, who really launched a number of the smoke-free Gov platforms, talked about this in terms of even if you're going to the best smoking cessation treatment program and you're getting weekly sessions with somebody, you still have 6 days in between that you're dealing with cravings, withdrawal, how do I deal with this particular situation? This is like having a virtual coach on your shoulder that's continuing to provide support and tips. And we do get very good feedback from providers. Here's just an example of what a message might be in terms of medications. We do what we can in 120 characters through the message program. For those of you who are VA clinicians, these are just some of the links to some of the resources we have. We have an internet site for veterans and family members, but also does include publications and print resources for patients and providers that non-VA providers can also resource. We have an internal SharePoint site for VHA clinicians that our amazing health system specialist, Ms. Jenny Knopel, organized for us. It has a wide array of resources. We also have every other month webinar that provides CEUs. We have a monthly community practice call. And we also have a tobacco cessation consultation service. Dr. Tim Chen, who's a clinical pharmacy specialist, Dr. Mark Myers, who's a clinical psychologist at our field-based San Diego Tobacco Cessation Clinical Resource Center. They actually provide consultation to VA clinicians who may have questions about how to improve tobacco cessation care at their site, how to set something up, if they have a particularly challenging patient with regard to behavioral counseling questions, or a particularly challenging presentation in terms of pharmacotherapy consultation. Dr. Chen and Dr. Myers can help them. And so finally, in conclusion, this is just the name of who we are and who we have at our site. And with that, I'm happy to take any questions.
So Kim, that was amazing. So for you all attending, I had said to Kim, wow, you've got a lot of slides. And remember, we only have 1 hour, but actually less than that because of, having to do the introduction and at the end to share the CEU information. So I'm so impressed. And that was so chock full of amazing information, but let's go ahead and open it up. I did, if you want to look, Kim, at the Q&A box, I went ahead and answered some questions for you.
Okay, answer, I see it, got it, okay. Yes, Chantix varenicline is an FDA-approved medication, and so that's the medication I was talking about in terms of VA's somewhat complex history with varenicline. We are interested in making sure that more patients have access to varenicline. We're hopeful that we're beginning to talk about revising the criteria for use of PBM actually this year, so we're hoping we'll have some more news that we can share at some point about this as well. I see you have said slides will be available. That's great. Okay. Other questions that folks have or comments?
So Brent just typed in another one, Kim, in the Q&A.
Okay.
Are there any policy changes at the systems level that would help treat tobacco use? For example, VA has a tobacco ban. Anything else that comes to mind?
I think the biggest challenge in VA that we have, that I know other program offices have as well, is that a lot of providers are doing amazing jobs doing tobacco use treatment as part of other duties as assigned. And so when you don't have people who are dedicated even half time to just doing something as complex as tobacco use treatment in a patient population as complex as we have, people sometimes really feel quite overwhelmed that they can't see as many patients, or they don't have as many patients, or they're feeling divided up in terms of that. So I don't think there's national policy ways to address that, because we can't mandate that everybody have that just by virtue of the fact that we don't have the budget to mandate that. But it really is a matter of, I think what we've done is tried to work with providers about ways that they can reorganize care so that it's basically making patients aware of the breadth of things available, that they can think about working with folks so that they don't become the one person in their facility who gets everybody who smokes, because nobody can take care of all those patients alone. It really is a matter of thinking about what's a step care approach to facility look like. What can primary care do in the way of medication, brief counseling, versus which kind of patients are going to need to be involved in terms of individual and group counseling because of the complexity. And also we've worked with sites who've been very effective in making really wonderful business case presentations to their leadership saying, here's why we need somebody doing this full time. This is a leading cause of preventable death and disease in the US. We also know that smoking related illnesses basically account for a significant percentage of VHA healthcare costs. So let's invest in this, let's do that. And a number of sites have actually been quite successful in doing that. And I think that's something we're always helpful to have connect people to other providers who've been successful in doing that, because they know what works at the local level in terms of engaging their leadership more than we do at VACO.
And Kim, with my inpatient hat on, I do just want to say that it actually is a Joint Commission requirement for anybody who's admitted to inpatient mental health units to be offered tobacco cessation services. And so hopefully,
and we work a lot with RAPID. I can never remember all the things RAPID stands for, but it's basically the office that oversees that performance measure. Dr. Doris Vahey is the person who is assigned the tobacco measures, both outpatient HEDIS-based measure and the inpatient Joint Commission measure. So we work a lot on what are ways to do that within the challenges, because when I did in consultation years ago as a clinical health psychologist working in pediatric hospitals, I know how hard it is to basically get things done in terms of those kinds of intervention, any kind of behavioral health intervention during an inpatient admission. So we worked a lot to come up with ways to support sites that are saying, gee, how do I meet the tobacco 40 measure? That means that somebody who wants to help with quitting smoking has to have an appointment before they leave. So we spend a lot of time on that. I think I've had 2 emails on that this week alone, because people are now looking at performance measures again now.
Yep, and like you said, really helping folks with comprehensive, not just mental health services, but addressing their health care is something that we definitely want to provide on inpatient mental health for our veterans. Is there anything, Kim, that you would have liked to have spent more time talking about, because we have a little bit more time?
Yeah, I think
that you didn't get a chance, to cover in your slides.
Sure. I mean, I think 2 major points that are really important to take away, because, I didn't do this when I was a clinical psychologist in academia. I didn't do this when I was doing health policy, when I moved over to a policy position following actually an APA Congressional Science Fellowship years ago that then led to me working in a Senate committee. I came to VA to do HIV prevention, and I did HIV prevention and really enjoyed that, but it was really clear that this was a topic that needed a clinical psychologist in public health, so I got assigned. And I think for me, what engaged me as a clinical health psychologist was the fact that basically, this is probably an amazing opportunity in some ways to do so much for patients that we just don't think about on a regular basis. I think about Miles McFall, who many of you knew, who's a clinical psychologist. He was the lead on Cooperative Studies 519 that looked at integrating smoking cessation to PTSD care. And Miles said that he got involved in this because, he was a PTSD psychologist. That's what he did. But he just got, so many years he felt like he worked with people who were doing better with their PTSD, and only to see them die of smoking-related illnesses. And smoking is a health disparity among mental health populations. And I think in VA, we've been getting that longer than some other agencies and other places. We know this population smokes at a higher rate. They suffer a higher economic and health burden. They have been targeted in the past by the tobacco industry. They have a longer duration of smoking, and they have a harder time quitting. And outside VA, not inside VA, they have limited access to treatment. So the one wonderful thing about working in an integrated healthcare system is our patients who are smokers have access to mental health. That's what the quitline is thrilled about, because they work with so many people who have mental health disorders who call the quitline, and they don't have those resources. So our patients have access to both, and so really ensuring that they get everything they need. I think the other thing is mental health providers are uniquely qualified to do this, because we basically are all trained in terms of how to do ongoing contact and addressing chronic disorders, and we have the skills to deliver tobacco cessation counseling. And I wasn't, but many of you have been trained in substance use treatment as well. So I think we are uniquely qualified to make a difference in this area, and to also engage our colleagues in terms of what their potential is to make a difference as well.
That's awesome. And as I mentioned at the top of the webinar, this webinar and Dr. Hamlett-Berry's slides will actually be available for you to share with your colleagues. They will not be able to get the CEU credits. Only those of you who attended the live webinar can do that, but at least the information is so super helpful and amazing. And, you know, like I said, free to disseminate amongst your colleagues and spread the word that that Kim just talked about. Any other questions that folks might have? I think people are actually able to unmute themselves and speak, although they might not. I don't know if anybody wants to try that, or any other questions that folks might have. You can post in the Q&A box.
And please feel free to reach out to me after this talk if there's anything I can do to help, or if there's any questions that you have. We're happy to help. That's why we're here.
And do you want to put your email address in the chat? So folks,
I will. Let me do that.
super awesome.
Because it is different than my last name, because I've had my VA email address even longer than I have been married.
Do you want to remind folks to get your CEU credit, you will be sent the survey link after the conclusion of the webinar, but I also posted that in the chat box. We do need you to complete that by May 12th. Dr. Spinola will at that time sort of close out the survey and get the CEU certificates prepared. If you are a Division 18 member, this webinar has been free for you, which is awesome. Otherwise, our CEU fee is $15. That's payable to our Division 18 VA section PayPal account. But it's also a good idea for you to join Division 18 if you're not currently a member, because as you can see from our webinar site, I will post that in the chat as well. It's in the Q&A answered section, but I will post it in the chat. You definitely get your money's worth if you attend all of our webinars and get CEU credit. It will take about 2 weeks for you to receive your CEU certificate, but everybody who has registered should get a reminder email in the next day or so. Grabbing the website address. There it is for all of our webinars. Okay, well, if there are no additional questions, thank you so much, Kim. That was just amazing and chock full of so much information. Your expertise is really impressive, and you know, it's so great to have psychologists who are involved from a health psychology perspective to help veterans be healthier. Like you said, that it impacts so many other components of health, and if we can get more folks to quit, then obviously that's in their best interest. So
well, thank you for the invitation.
All right. Well, great. Everybody have a fantastic day. I'm stopping the recording.